This is a further analysis of the Women's Health Initiative randomized clinical trial evaluating estrogen plus progestin. You're very familiar with this study, I'm sure. Began in 1993. Otherwise healthy women, you can see 50 to 79 years of age, no prior chemotherapy, no prior hysterectomy, testing for the first time whether estrogen plus progestin combination versus placebo would have a favorable effect on chronic disease risk. As you can see on the bottom, the study was stopped in 2002 when the global index of the monitored diseases indicated more risk than benefit. There were more myocardial infarctions, strokes, breast cancers in the estrogen plus progestin group. And so what happened is 98% of the women stopped their intervention. After intervention, we continued follow-up. This data was reported last year in JAMA. After the intervention, we saw a trend to increased all-cause mortality in the women who had previously received estrogen plus progestin. You see the hazard ratio of 1.15, which wasn't significant. With further exploration, we saw that there was an increase in fatal and non-fatal malignancies. For overall malignancies, there was a significant increase of 24%, as you can see. And our question was, does CE plus conjugated equine estrogen plus medroxyprogesterone acetate influence on lung cancer incidence and outcome afford a potential explanation? So we went back and essentially adjudicated all the lung cancer cases and then are looking at them within the context of this randomized clinical trial as really a secondary endpoint. And here this slide summarizes two things. On the left-hand panel, you see the non-small cell lung cancer incidence. I should say the small cell lung cancers did not vary at all in incidence or outcome. So there's no effect on small cell lung cancer. You can see the non-small cell lung cancer incidence showed a non-significant trend for more cancers, 28% more cancers, with maybe a visual trend towards the curve separating over time. And then on the right-hand panel, we see what happens if a woman developed breast cancer while she was on CE versus MPA, and we see a substantial difference in outcome. You see 59% increased risk of death, which was statistically significant. You see the numbers on the bottom, 67 versus 39 deaths, 70 versus 54% mortality, median survivals of 9.4 months versus 16.1 months in favor of the group that did not receive the estrogen plus progestin. I should say smoking was completely balanced between the two groups. 50% of the women entering were non-smokers, 40% were past smokers, and 10% of the 16,000 women were current smokers at the time the study started. 30% of the women in both arms continued their study medication after their lung cancer diagnosis. That was not a protocol requirement that they stop their combined hormone therapy after lung cancer diagnosis. When we put those two curves together, that is the fact that there was a trend towards increased incidence and there was an overall survival detriment after recurrence, we see what happens when we're looking at the entire population of 16,606 women and seeing what is their risk of death particularly from non-small cell lung cancer. You can see the curves diverging 3 standard deviations, with women having an 87% increased risk of dying of non-small cell lung cancer, which is the leading cause of cancer death in women. I think I will spend more time on this slide. This is because I think this is the major concern is what are the absolute risks. I think we're always, we showed you a big relative risk of 87%, but here we break down the absolute risk. On the top line, you see for overall patients, you see the hazard ratio of 1.61, but you can see for the never smokers, in orange, their risk, never smokers who didn't receive hormones had only 0.1% risk of developing breast cancer. It goes up in the smokers, but when you look at the bottom line, the current smokers, 27 deaths out of 800 versus 19 out of 838. There's a number of ways of looking at it, but there's an excess of 8 non-small cell lung cancer deaths for the 800 women participating in this trial who received estrogen plus progestin. So that's about 1 out of 100 women who were current smokers entered the trial had an otherwise avoidable death from non-small cell lung cancer. So, and I recognize that the numbers are, absolute numbers are quite rare especially in the large non-smoking population. So here are conclusions. Conjugated equine estrogen and medroxyprogesterone acetate for somewhat over 5 years significantly increases death from non-small cell lung cancer, the leading cause of cancer death in women. In current smokers, about 1 in 100 experience an avoidable non-small cell lung cancer death with CE plus MPA over the 8-year study period. So current smokers using combined hormone therapy should discontinue tobacco use. Current smokers should also carefully consider this mortality risk before beginning or continuing combined hormone therapy. Thank you.
Thank you. One of the things we had a discussion about before here is that here in a carefully controlled randomized study taking a look at hormone replacement, they saw an increased risk of lung cancer as well as a worse outcome. This is a bit in contrast to the majority of case control studies where they take a look at people who either have lung cancer and age-matched population where you see either no difference or a reduced risk. This is likely more accurate since this is controlled in a prospective randomized study.